on behalf of RAISA, we welcome our beloved Professor Dr. Rakesh Garg from All India Institute for our very much awaited and very much interesting academic session guest lecture. And I our President Dr. Atul was and very much enthusiastic postgraduate students from the DNB courses and other allied medical colleges. On behalf of RAISA, I invite our guest lecturer, Dr. Professor Rakesh Garg, to deliver a very interesting lecture, very valuable lecture on basics to the best practices in onco-anesthesia. Over to you, sir.
Thank you so much, sir. Thank you so much for your kind invite, and thank you to all the participants as well for spending time in this early morning. So in this series of Onco-Anesthesiology lecture, I'll be talking about the Onco-Anesthesiology because there are certain concerns which are different from other general anesthesia practice. And these concerns are important to understand because the outcome of these patients would depend upon the preoperative evaluation, the intraoperative management, and the postoperative care, which is little different, require a little different approach when these patients of cancers undergo surgical procedures. So in next around 45 minutes to 1 hour or so, we will discuss the basic aspects of the onco-anesthesiology. And in the next series, we will discuss about some specific aspects, some focus aspect, which are very, very specific to onco-anesthesiology practice. So I bring greetings from my institute. I work at Cancer Center of All India Institute of Medical Sciences. Now, having said that, when we understand the cancer patients and when they are posted for surgical intervention, their perioperative management, you can say the anesthesia remains the same. There will not be their same drugs, same monitoring systems, same analgesia technique, but the approach to these patients with regards to various aspects, whether we talk about the drugs, whether we talk about the approach, whether we talk about the post-operative care and concerns, they are a little different, and how we will in next 45 minutes are going to discuss those aspects. Now, when we talk about cancer patients would be undergoing various aspects of treatment before the surgery, during the surgery even. For example, say there is a concern like intraoperative chemotherapy, intraoperative radiotherapy, which are the concerns, and we are going to discuss in the next session. And also post-operatively, these patients would require chemotherapy and radiotherapy. So this means the additional treatment these patients are receiving, this will have impact on the patient, which will mandate the adjustment or change of strategies in the perioperative care for these patients. So they need a different approach. They do need a different technique. Now, why cancer patients will come to us as anesthesiology? We all know that, yes, we are doing for a surgical procedure, but as an anesthesiologist, your role in cancer patients are multi-pronged. You would be required at different places in cancer patients when you're working in a cancer center. You may require for preventive strategies where removal of organs in genetically acquired conditions and they are posted for various chemotherapeutic agents or cancer treatment. You may be posted for diagnostic procedures. Sometimes they require difficult biopsies, like for example, say intrathoracic from the lungs, which has a big concern. Sometimes they would require endoscopy, deep endoscopy procedures or stent placements, which could be not only for GI, but also for endotracheal, endobronchial, and lung biopsies through the endoscopic routes, or maybe through the ultrasound guided endoscopic routes. So this will require some amount of sedation, at times anesthesia also, and hence you would be required. For the purpose of staging of these surgical procedures to make a plan of care for cancer management, the exploratory surgery, usually laparoscopically being done, is required. And obviously, curative intent, these patients are posted for the removal of the tumor mass, which is the curative intent. But at times, it will also be required for debulking because there may be a large mass which is causing a lot of obstruction, a lot of symptomatology, and hence debulking will be required. And subsequently, now debulking is being done because there are other treatment modalities like intraoperatively chemotherapy or radiotherapy, which can take care of the residual tumor. And hence, these cytoreductive debulking surgeries are important. Also, anesthesiologists are playing an important role in palliation of these patients because at times when these patients have advanced cancer, these patients may have various symptoms. And for symptom management, anesthesiologist is one of the good specialists who can take care of its various symptoms like pain management, nausea, vomiting, malignant spinal cord compression, dyspnea because of pleural effusion. So anesthesiologists are playing a role as palliative physician also. Also, sometimes you are required for supportive therapy. For example, when patient is posted for chemotherapy, they are not able to get a vascular access, or sometimes chemo port or Hickman catheter is being placed. Then again, as a supportive role, anesthesiologists play a big role. And at times, you may be for any other incidental surgeries also, wherein, for example, a patient of cancer being operated for, say, appendicitis, which can happen because of the various impact of cancer or the treatment itself, maybe undergoing treatment or a cancer survivor. So this means the role of anesthesiologist is having a broad spectrum, and various concerns are there for each type of its role. Whether we talk of diagnostic, yes, if you are doing endotracheal biopsy procedures, then obviously it will have major issues because there could be hypoxemia. And hence, the role is getting more broader, and hence the concerns, and hence we need to understand that how we can manage these patients safely at whatever place we are going to manage them. Now, if you talk about the cancer patients management, obviously, these patients come for POCs, they go to operating room, they go to recovery room, discharge, surgical OPD, consultation, and comorbidities. But remember that this is not a one-time procedure. Many of the time, these patients may come for repeated procedures. First time, they may be for diagnostic. Second time, maybe they may be for curative intent. Or subsequently, they can be for palliative procedures also. And hence, it is required that each the surgical procedure, each time a patient comes to you, he will not be the same. There would be changes because of the cancer progression or because of the other treatment like chemotherapeutic agents they are receiving. They will have different conditions, and hence they may have exacerbation of the various comorbidities. And hence we need to understand and assess each time this patient in detail so that we are able to take care of these patients much better. Now, I just mentioned that the perioperative management of oncosurgery are different, and if just I want to summarize, this could be in a single slide. I can summarize that the concerns and challenges in cancer patients who are posted for surgical intervention are due to the impact of cancer per se. Whenever the cancer happens, they cause various mechanical, biochemical, physiological impact in the patients, and hence these are important to understand. They could have systemic effect, they could have local effect, I just mentioned. The impact of treatment received for cancer. These patients may have, I just mentioned, may have undergone the surgery earlier. There could be a lot of adhesions, scarring, contractions. They may have received chemotherapy or radiotherapy. They may have local or systemic effects. I'll be coming a little later. And drug interventions for cancer pain management. These patients, because of cancer, may be receiving certain other drugs, which you need to understand. They may have other associated comorbidities. For example, certain chemotherapeutic drugs causes various cardiac function disorders, respiratory function disorders. They cause immune suppression, and hence needs to be understood. We know that psychological impact is one of the very important aspects, and hence we should be very careful that these patients would require not only the psychological assessment, but at times support also in the perioperative period. The oncosurgeries, they are different. They are at times prolonged. They cannot be straightforward. Once the surgeons open up the abdomen or the thoracic cavity, they realize that it is extensive, too extensive. They need to take a decision whether to operate or not. And hence they have issues, concerns, bleeding, fluid management, pain management, and many other things because of the surgery itself. A more recent concern is about the cancer recurrence. When we say the cancer recurrence, it has been seen that the perioperative care, including the anesthetic management, including drugs, techniques, have some influence on the cancer recurrence. So it's a big concern, because if we give a drug which is supposed to be causing some immune changes in the body with the possibility of cancer recurrence, then we need to avoid it. And there is some emerging evidence, though it is not very robust as of now, to say that this drug is definitely causes cancer recurrence. But yes, there is some emerging evidence of certain drugs which are going to discuss subsequently. And hence, in view of all those concerns and challenges, it not only required a thorough preoperative evaluation, but also we need to have a plan of anesthetic management with standby or rescue, because as I just mentioned, there are many times there will be a change in the plan in the intraoperative period. Maybe they just thought of that it's a small uterine mass and they will be able to excise total abdominal hysterectomy only because of endometrial carcinoma. The rest of things appears to be normal. But when they open, they find that there are small nodules, there are adhesions, there are caking of the pelvic area. Hence, they will require extensive surgery, maybe to the extent of sometimes exenterations. So this means we need to have just not a planning, but also a rescue measures, because the plan can change intraoperatively. Now, goal of the perioperative care of cancer patients is primarily to give them a good quality, and hence the optimization is important, and from various aspects. Concerns I just mentioned. So we have to include just not the physical assessment of these patients, but we need to look for behavioral, physiologic, hematologic, and nutritional optimization of these patients, because cancer and the treatment may affect each of these, and hence needs to be assessed and optimized preoperatively. Goal-directed, data-driven, evidence-based perioperative care. We have a lot of evidence now for the management of these patients, and hence, based on the patient's individual assessment, an individualized approach needs to be provided to these patients. We need to provide them a satisfactory analgesia so that patients' needs and expectations are taken care of. At times, the surgeries are extensive. Patient requires a good analgesia so that they come back to the normal life with good quality of life. We need to individualize perioperative care to faster functional recovery. And now, moreover, we say for the recovery to the extent that their cancer therapy can be started or resumed, because many of these patients would be requiring post-operative chemotherapy or radiotherapy. If the recovery is not good, the chemotherapy and radiotherapy may be prolonged. Usually it is done between 4 to 6 weeks, but if the patient is not returning normal to his functional capacity, they may be delayed, and hence there will be a chances of suboptimal response to these type of post-operative therapy. These patients are also at risk because of many factors. Thromboembolism, they could have deep thrombosis, they can have leading to venous thromboembolism, and hence these patients, cancer patients, would require care of various prophylaxis for preventing venous thromboembolism. Also, we need to remember that the outcome of the cancer, as I just mentioned, depends upon the perioperative management. The cancer recurrence, the chronic symptomatology in these patients, like chronic thoracotomy pain, chronic breast syndromes, chronic cancer pains are common to the tune of almost 20 to 80% in these patients. And hence, we have to look to prevent these chronic sequelae of the perioperative care, and thus to improve overall oncologic outcome for these patients. Now, when we say about the cancer patients, usually it's a teamwork, because there will be a lot of people who are involved in pre, intra, and post-operative management. And hence, the team approach, which requires just not the anesthesiologist, operating room staff, the surgeon, but also the other medical oncologists, radiation oncologists, nutritionists, dietitian, they will all be required to manage this patient to improve the outcome. And this will require any delay in patients' management, because we cannot delay indefinitely these patients for long duration, because there will be a chance of cancer progression, metastasis, or local advancement. And hence, it is very, very important for anesthesiologists to take a lead role so that these patients can be managed properly. Also, we need to remember that these patients could have various comorbidities. As I was just mentioning, this could be related to, this may be unrelated to cancer. They may be pre-existing. But just remember, for example, say smoking is a known risk factor for lung cancer. So this means those patients who have lung cancer probably has a history of smoking for long duration, and hence they will have changes in the lungs, a smoker's lung. So that needs to be taken care of. That needs to be optimized and assessed. These patients may have diabetes, hypertension, hypothyroidism, renal derangements, respiratory failure. That needs to be taken care of. Also, we should be careful, like in patients with liver metastasis or liver issues, they can have DVT or they can have jaundice, and hence these patients would have altered hepatic metabolism, and various drugs that we're using, they could be concerned. There could be concerns with regards to the protein issues. They could be regard to the detoxification of various agents and drugs, and hence it becomes very, very important to assess these patients from this point of view also. And obviously, these patients may be alcoholic and smoker, and hence you should be looking for the sequeling of the body effect, systemic effect because of smoking and alcohol use. And now, if you see the data, we have seen even at our center that the patients who come for various cancer surgeries, they have various comorbidities starting from hypertension, ischemic heart disease, diabetes, thyroid disorders. So these are the various issues that has been seen in this patient to an extent of almost 20%, 20 to 30% of these patients will have these comorbidities, which is pretty high. Now, when we talk about these comorbidities, we need to remember that comorbidity is not individual thing. I just mentioned that smoking causes lung cancers, smoking also causes COPD, smoking also causes cardiac issues, smoking also leads to ischemic heart disease, smoking may also lead to peripheral vascular disease. So this means any comorbidity which is happening, which is probably a factor for cancer, but also will be affecting other aspects. So these are the core aspects that we usually talk of, but also we need to look for the various functional status and frailty. Now, frailty is one of the important aspects which is emerging in cancer patients. These patients, because of this frail nature, because of the impact of cancer and its treatment on the body, change in the physiological aspect of these patients may not be able to tolerate major surgical interventions. The functional status may not be good, and hence overall the cancer outcomes becomes hampered. If they are frail, if they are functional status, a suboptimal therapy probably would be allowed in these patients because they may not be tolerate the full dose of chemotherapy. They may not be able to tolerate extensive surgery like exenteration or cytoreductive surgeries like HIPEC procedures, and hence the cancer outcomes would be affected because of this. And it is, if you see this chart, you can easily say that the interaction between comorbidity and other related constructs, specifically patient factors, frailty, and functional status, are interlinked, and hence the impact on the overall cancer outcomes would be seen in these patients. Now, whenever these patient comes to us, what needs to be looked for? We need to look for various preoperative investigations. Now, probably we'll be having our Indian guidelines very soon with regards to the preoperative investigations. But if you see for the cancer patients, the preoperative test should not be ordered routinely in all patients of all types. So it has to be some individualized. So there is some evidence based on this, based on which we can think of. And the preoperative test may be ordered, required, or performed on a selective basis, which will probably help you to make up goals of care, or which will change the goals of care for you. For example, a patient who is having hepatic disease, having jaundice, probably you require LFT and coagulation test for these patients because this may be required for your management, whether you want to put a central neurexia block or not. But if the patient is not having any other disease, a small lump somewhere, young patients, probably he will not require the coagulation test or probably the LFT even for these patients as a routine matter if there is no other abnormality detected. So this means the more recent test results may be desirable when we talk about the timing, because the cancer patients may have progressive physiological changes because of either cancer progression, or the patient probably has received some drugs, chemotherapeutic drugs or radiation drugs, and these interventions have impact on the patient's physiology, patient organ function, and hence once these chemotherapy, radiotherapy, or other interventions are over, if there is any change in the clinical presentation of the patient, probably you will require a repeat of the preoperative testing, because they will help you to select or plan a specific anesthetic technique based on those physiological treatments. As a part of evaluation, these patients do require clinical assessment, look for various signs and symptoms of pulmonary compromise, like for example, say CL lung, receiving chemotherapy, maybe having high risk of infection. Look for dyspnea, non-productive cough, pleurisy, crackles on exam. The chest radiograph, PFT, arterial blood gases, and assessment of diffusing capacity would be required in patients who are having lung changes, significant lung changes, and clinical signs and symptoms shows a significant compromise. Probably then you require these additional tests. So these additional tests are based on your initial assessment, clinical assessment, and then you can think of. Patients who are having restrictive lung disease, increased alveolar arterial oxygen gradient, or a decreased diffusing capacity may require special pulmonary care in the perioperative care. So these testing probably would help you to plan the anesthetic management, whether these patients would require some amount of postoperative respiratory support. So these things need to be evaluated in these patients and managed accordingly. Now, this is an emerging tool, which is cardiopulmonary exercise testing, which is not only a very holistic tool which assesses the cardio function as well as the respiratory function, and the functional capacity, overall functional capacity is being assessed, and the same tool is used as a part of rehabilitation also. What is this rehabilitation? I'll be coming into the next session probably, but this is coming a very good tool which will assess a holistic cardiorespiratory reserve of the patient in a very holistic way, and it is one of the very good tools which is emerging in assessing these patients. Now, coming to the urgency of the surgeries. Now, you must be remembering this ASA classification of the urgency of surgery. We say the emergent surgeries, which are life or limb threatening, if no surgery is done within 6 hours. Urgent surgeries, life or limb threatening surgery, if not done within 6 to 24 hours. The elective surgeries, which could be delayed up to 1 year without any harm or adverse events. And time-sensitive surgeries, where the delay of surgery for more than 6 weeks will affect the outcome of the patient. And all the cancer surgeries are time-sensitive surgeries. We do have time, but earlier we do, better it is. But then this should be done within 6 weeks of the diagnosis of cancer of these patients. So we need to remember that the impact of chemotherapy and radiation therapy is time dependent but very variable, and this will allow you to keep this duration also, because if somebody has received chemotherapy or radiotherapy, usually they keep 4 to 6 weeks of gap between the last cycle of chemotherapy plus the subsequent surgical procedure. So to summarize, the oncosurgical procedures are time sensitive. They cannot be delayed for very long. They are not elective procedures. But yes, you do have some time for good assessment of these patients, and optimization of these patients should be started from the day 1, so that by the time they are posted for surgery, they have been optimized to a large extent. The concerns, as I just mentioned, there are many, and the point I want to just raise from this is that you need to look for holistic assessment of these patients, not only the patient's condition, but also the impact of various drugs. And as an anesthesiologist, you should also be very, very well versed with looking for the imaging. As an anesthesiologist, we at times are not very expert in seeing the CT scans, MRI imaging, ultrasound for these patients, but we should be in a habit to either learn or at least discuss with your radiologist colleague to identify various concerns, so that you can manage your anesthetic management more better. For example, a patient who is having, say, lung cancer, and it is abutting some amount of bronchus or something like this. If you know your imaging well, you can think of the airway management plan for these patients. So that's why, as an anesthesiologist, the another concern is to understand the investigations and the imaging commonly either alone or we can discuss with our radiology colleagues so that we can take care of them. Now, we also need to understand as the basic aspect that the cancer patient, I was just mentioning the impact of chemotherapy and radiotherapy in these patients. But what are the various options are provided as a part of therapy for these patients? These patients probably would require chemotherapy, which is one of the common modality along with radiotherapy. But now we have other therapies for cancer also, which includes targeted therapy, which has monoclonal antibodies, the inhibitors. They also being taken up. Newer modalities are the cellular therapy or cytokine therapy. So these are the other therapies we need to understand because they have some implications in the perioperative care, and hence these patients may be on these therapies apart from the chemotherapy and the radiotherapy. And hence we need to assess these patients for these agents also and their impact on the body system. Now, when we talk about the chemotherapy toxicity depends upon many factors. Now, this would be primarily based on the type of chemotherapeutic agents that you're using, that which organ system is primarily affected and to what extent. And toxicity profile of each chemotherapeutic agent is a little different. Some affect more of the cardiovascular organ, some affects the kidney, some affects the liver, some affects the lungs also. So this means you need to understand which drug and its toxicity profile, timing, and the cumulative dose. Now, when these patients are receiving therapy, though there will be a suitable gap between the cycles of chemotherapy and the body will try to recover during this gap to a normal function, but each additional dose of chemotherapy would have effect on the body system, and hence the cumulative dose of the chemotherapeutic agent which has been administered also needs to be looked for. As I just mentioned, that with time the organ functions try to improve back to normal, and if some urgent intervention is required during this process when the body is recovering, obviously the outcome may be affected because the body functions are deranged. The patient status is again very important in cancer patients because of cancer, because of treatment, these patients may be dehydrated, there may be nutritional issues, their physical status is not good, the ECOG score is not good, and these patients may not be able to tolerate various cancer treatment, and hence at many of the places these patients are just posted or kept for best supportive care because of the poor physical status of these patients, and hence this becomes very important. We should not be just going for an extensive surgery in a patient who is having a BMI of say 10, 12, 13, 14 or weight 30, 40 kg with albumin levels of 2.3 and the METs is less than 2. So these patients may not be able to tolerate the extensive surgical procedures, and hence patient status must be assessed in these patients. The toxicity profile of various agents, as I just mentioned, can be on any of the body organ systems. It can affect the airway, the cardiovascular system, the respiratory system, the kidneys, the neurological. They can have chemotherapy-induced neuropathic pain, hepatic functions, hematologic. They may have low platelet counts. They may have low TLC counts because they can lead to bone marrow depression. And there can be a lot of GI effects, especially like mucositis, paralysis, and so on and so forth. And hence, we need to assess these patients holistically because our perioperative care would depend upon this. They may also have coagulopathies, thrombocytopenia, and anemia. They may be related to the bone marrow suppression. They may be related to the bleeding, and hence needs to be assessed. Also, these patients may have various concerns like immune dysfunction, the SIADH. They may also be receiving steroid. They may have complications of tumor like tumor lysis syndrome, hypercalcemia, other renal manifestations. So these can be all having these issues and hence needs to be looked for. Now, when we talk about the chemotherapy side effects, when we look for the chemotherapy side effects, which I just mentioned about these effects, these could be immediate or delayed or late. So this means depending upon the drugs that you are using it, certain side effects will be immediately manifested within 24 to 48 hours. some will be delayed, which may come within days to weeks, and some will be manifested late and will depend upon the long-term impact. For example, some amount of mucositis leads to fibrosis, and subsequently some amount of respiratory dysfunction will be persistent into these patients. And hence, we need to look for, that's why I mentioned during the assessment part, we should be looking for the timing and the cumulative dose of a particular chemotherapeutic agent that has been given to these patients for managing that. Now, if you see the chemotherapeutic drugs which has been given, usually like, for example, 3 to 4 weeks, usually 3 to 4 weekly, these patients are given these drugs. So usually the acute event will be like, say, hypersensitivity, nausea, vomiting. There could be issues with the lower GI like mucositis, diarrhea. There could be renal dysfunction, fatigue, and nutritional issues. These are usually manifested early, but subsequently there will be effect on the bone marrow suppression, leading to fall in the counts, platelet counts, anemia, neutrophils. There could be leading to infection and bleeding. There could also be derangement in the liver function. These patients may have increased liver enzymes. Their bilirubin may rise, and then subsequently they will try to recover in 3rd week. And that's why these chemotherapeutic agents are given accordingly. So they are usually given 3 to 4 weekly, because these patients will start recovering from 3rd week to 4th week. And once the patient is recovered, again they will give the 2nd cycle and subsequent cycles of chemotherapy. So this is how you need to understand that if somebody is posted for some emergency surgery during the 1st week after the administration of chemotherapeutic agents, they will be having a lot of issues. With regards to the change in the physiology. Now, I was just mentioning about the long-term impact. Even if some patient has received a couple of cycles of chemotherapy a couple of months back, there could be persistent effect on various organs. For example, say bleomycin. It causes a lot of interstitial injuries in the lungs. The doxorubicin, it causes cardiomyopathy, hypertension, ischemic heart disease, conduction system abnormalities. And cirrhotic changes can be seen in metabolites of the chemotherapeutic agents. The chronic renal failure can be seen with cisplatin. Infertility is affected because of the many of the drugs, and these drugs can even impact on the leukemias and solid tumors. Now, coming to the other aspect that you also need to be remembering is the effect of the radiation therapy. Many of time these patients would be receiving external beam radiation therapy, which is one of the cornerstone for treatment of cancers. Now, there are 2 aspects. One, as an anesthesiologist, at times you need to provide the sedation or the anesthesia for usually the pediatric population. Also, sometimes patients, the adult patients who have received radiation therapy preoperatively will be posted for surgical intervention. So there are the spectrum of conditions where the radiation therapy is concerned to you. Usually, depending upon the type of cancer, they receive the cumulative dose 25 to 80 grays, which are divided into fractions. This high dose cannot be given once because it will lead to a lot of side effects, and hence it is usually divided into fractions, 20 to 30 fractions, and given on a daily basis, usually 5 days a week, and they continue for a month. The toxicity profile would depend upon the cumulative dose, and it also depends upon the site of radiation. If something is being given to anterior chest, then probably the patient will have some impact on the cardiovascular function, the lung function also, and the timing. As I just mentioned, these patients would have concerns related to the timing, because the radiation side effects obviously improves with time. So if again some patient is posted for surgeries during this recovery profile, they will have a lot of concerns, which is the side effect or the toxicity profile of this radiotherapy. Now, when we talk how basically this radiation therapy has impact, so whenever the radiation therapy is given to a patient, it causes ionization in the tissues, will lead to the formation of free radicals, and they also damages the DNAs of the body, leading to cell death. So this is primarily the advantage that we want for the tumor cells. But then obviously this will also lead to the not only the tumor cells, but the surrounding cells will also be impacted. Though we have better planning and radiation exposures for these patients, so that they have more impact on the tumor cells, and rather than having minimal impact on the normal surrounding cells. but still some of the cells will be affected, and hence the healthy cells near the treatment area would also be damaged because of this, and hence would be the toxicity that can happen. And this will depend upon part of body, dose, and ability of healthy cells to repair damage. As I mentioned, that within a certain time, the cells which has been impacted will try to recover of its own, and they will start functioning. But then, yes, good support, a good nutrition needs to be maintained during this time so that the body recovers to normal. Now, this is one of the important aspects, the mucositis. Now, because mucositis does not lead to a lot of amount of pain, but it can lead to vomiting, diarrhea, airway management difficulty. It can lead to fibrosis and hence decrease opening of the oral cavity in the mouth, and hence will have a lot of other issues, like for example, nutritional issues. They will have low albumin because not only diarrhea, they will have decreased nutritional intake. They will have infection, fatigue, psychological issues would be there in these patients. There could be concerns with the social aspects. And hence, when these patients happen, you should be careful in assessing these patients for these aspects also. The other systemic issues, the other organ system are also impacted. So if you talk about the genitourinary and renal, it depends upon the tumor location. If it is a primary tumor of the genitourinary or renal, obviously the function would be impacted. But sometimes the nearby organs would be impinging. For example, if there is a tumor in the abdomen which is pressing over the ureter, so probably there will be some hydronephrosis, and as these patients would require preoperative media stent placement, right? So because to relieve this obstructive hydronephrosis. Not only this mechanical concerns, the chemotherapeutic agents can lead to direct tubular necrosis or renal changes, renal dysfunction, and actually needs to be looked for. Sometimes even not direct injuries, but indirect injuries. For example, whenever the chemotherapy is being given or radiation therapy is being given, they will have a lot of tumor lysis. The tumor cells will block up, and their necrotic materials will be released in the body, and they will be precipitated into the kidney, leading to renal insufficiency. And these effects may persist for several years after treatment, and hence it becomes important to assess the impact of these drugs depending on which drug has been taken, so that these patients remains controlled, and you are able to pick up these abnormalities and plan your anesthetic management accordingly. The gastrointestinal and hepatic physiology is also impaired. The chemotherapy can lead to the reactivation of various viral infections, including hepatitis B, and there could be an unexplained abnormal liver functions when these patients have been exposed to various chemotherapeutic agents. The chemotherapy can also lead to hepatic veno-occlusive disease, and whenever the patients who present with unexplained jaundice and ascites do look for hepatic veno-occlusive disease, which could be a complication of high-dose chemotherapy. Patients with cancer and cirrhosis, you need to assess these patients using appropriate tools, and the Child-Turgot and model for end-stage liver disease score. These are two tools which are usually used for guiding the perioperative risk assessment in these patients, and for the perioperative management and prognostication also. The various drugs that can lead to liver dysfunction includes methotrexate, L-asparaginase, cytosine, ribonoside, picamycin, streptozocin. So these are all drugs. If somebody has received it, you should be careful. You should also be looking for the effect of these drugs or the mechanical effect, maybe primary or a metastatic tumor in these patients, so that you are looking for the coagulopathy, the biliary dysfunction, and the malnutrition in these patients. The endocrine changes also happens in these patients. So these patients may have received steroids as a part of their chemotherapeutic regime, and hence these patients could be in hyperglycemic state. Patients who are taking prednisolone or equivalent of 20 milligram per day for more than 3 weeks, they will have HPA axis suppression, and hence you should be remembering that the supplement of steroids would be required in these patients in addition to whatever the routine dose they are taking. Radiations to the head and neck can lead to hypothyroidism, may develop 4 weeks to several years after radiation treatment. So take a history of these type of treatments, and if there is any clinical symptomatology for hypothyroid conditions, do look for and assess these patients for hypothyroidism. Even drugs like tyrosine kinase inhibitors, which I'm mentioning about, which are though different from chemotherapeutic agents like sunitinib and sorafenib, They can also call hypothyroidism. So these asymptomatic hypothyroidism could be seen in these patients, and that's why they may require thyroid supplements. In case if they are asymptomatic, you can proceed the surgeries as scheduled. But if they are having symptomatic symptoms of hypothyroidism, obvious symptoms, just not only to need replacement, but try to optimize the physiology to a large extent. But you cannot delay the surgery for long. These patients, the tumor itself can lead to carcinoid crisis. Now, these are a lot of issues where cardiorespiratory compromise can happen in tumors, serotonin-producing neuroendocrine tumors. They can lead to flushing, diarrhea, cardiovascular changes like tachycardia, arrhythmias, hemodynamic instability. They can lead to a lot of secretory materials leading to intense bronchospasm, delirium, and hence these patients would require looking for these tumors. So when you look for cancer surgery, also look for what type of cancer it is, what histopathology is, because these patients, these cancers will be secretory tumors, and hence because of those secretory materials from these tumors, they will have some issues in the body physiology also. They can also manifest with paraneoplastic syndromes. Paraneoplastic syndromes could be in the form of SIDH, Cushing syndromes, Eaton-Lambert syndrome, hypercalcemia of malignancy. And hence, when you're looking for these tumors, look for these type of paraneoplastic, and it has been seen that many patients would have, like for example, say lung cancers, for example, say adrenal cancers. They will have these type of paraneoplastic syndromes affecting the body. Now, next aspect that you need to assess for is for the airway management. These patients would have tumors in various areas, and hence the airway management becomes very issues, because they will have distorted anatomy because of these tumors, specifically head and neck cancers and even the thoracic tumors. And hence they may have all aspects of difficult management, starting from difficult bag and mask ventilation, difficult laryngoscopy, difficult supraglottic airway placement, difficult regional airway blocks, difficult surgical airway, difficult fiber optic bronchoscopy. And hence, just not the assessment, you need to have the equipment's expertise also to manage these difficult airways uneventfully. So whenever a patient receives the radiation therapy to the head and neck area, there could be trismus. The mouth opening becomes restricted because of the fibrosis and trismus. There could be limited neck extension because a lot of fibrosis happens in the neck area, and hence the neck movements becomes limited. Even, for example, during the airway management, we do optimal external laryngeal manoplation, which again will have limited mobility of pharyngeal structures because of the inherent mucositis leading to fibrosis after radiation therapy and chemotherapy. And hence, we should be looking for these issues in the airway during our assessment. So for the airway management, we should be having a systematic approach after a good assessment for these patients, and hence we need to manage it. We can use, there are many different guidelines which are available. Already a Difficult Airway Association has guidelines which has talked about the management of difficult airway in these patients. And similarly would be the extubation also, because extubation is again a big concern, because these patients will have not only pre-existing difficult airway, but after the surgery also they will have a lot of issues, edema, the anatomy distorted, there could be flaps, and hence the extubation also becomes difficult. We need to follow the algorithms which has again been given by All India Difficult Airway Association, as well as the Difficult Airway Society from UK, which has given these guidelines of extubating these patients with having difficult. And hence, when you look for the airway management, do have holistic approach for assessment. You plan your techniques, preparation accordingly. Extubate, do have a plan again, and these patients could have various complications at intubation, during the surgery, at extubation, and post-extubation. And hence, you need to assess these complications timely to prevent any events and then take it forward. The other important aspect that needs to be remembered in patients with cancer is related to the nutritional cataxia. So when we talk about the cancer patients, as I was just mentioning earlier, because of many reasons, these patients can have nutritional issues. Now, this is very important because, as I was just mentioning, if the nutrition is not good, we know that the albumin is an independent predictor of the outcome after a major surgery. So this way, if the nutrition is gone not good, probably they will not be receiving optimal chemotherapy also because they will not be tolerating it. But in cancer patients, because of metabolic changes, because of anorexia, and that can happen because of many reasons. The altered metabolism of carbohydrate, fats, and proteins, in addition to the impact of chemotherapy, radiotherapy, and surgeries, and the cancer itself, and various concerns like pain, nausea, vomiting, abnormal taste, abnormal smell, appetite, depression, weakness, GI obstruction. These all can lead to diminished intake and increased expenditures, and finally it leads to cachexia. And cachexia is one of the major issues in cancer patients, and it affects the outcome of these patients. Also, we need to remember that in cancer patients, as I was just mentioning, the impact of cancer, chemotherapy, and radiotherapy, we need to look for various concerns in the hematologic aspects. Now, anemia is one of the common aspects, and we know that the cancer patients may have a lot of blood loss, and hence we should try to attempt these patients as part of rehabilitation to build up their hemoglobin, so that they can tolerate the perioperative much less. We also need to look for various measures to decrease the perioperative blood loss. We can think of blood transfusion, but again, blood transfusion is a big concern because blood transfusion is an immunomodulator. It causes a lot of issues. It increases the chance of infection. It increases the chances of cancer recurrence by causing immunomodulation. So we should be very cautious when we are trying to use the blood transfusion in these patients routinely. That's why we need to look for other therapies to increase the hematopoiesis in these patients by supplementing with anemia, supplementing with iron and good nutrition so that they recover with the RBC aspect rather than giving blood transfusion for these patients. These patients can also have coagulation abnormalities, bleeding on one side and thrombosis on the other side, and hence we should be careful. Because of low platelet counts, because of liver dysfunction, they can have bleeding. Simultaneously, they can also have, because of various secretory materials where tumor cells, they are prone for DVTs leading to pulmonary embolism. And hence, we need to look for all those issues with regards to the cardiovascular and hematologic concerns so that we can take care of them appropriately and timely so that the oncology related outcomes are improved in these patients. As I was just mentioning, blood transfusion should not be taken lightly in these patients because we know that transfusion can lead to increased risk of infection, pulmonary and renal injuries, MI, strokes, increased length of hospital stay, increased perioperative mortality, increased cancer recurrence. And hence, we should be very, very cautious when we are thinking of hematologic optimization for these patients so that we are providing them an optimal care and judiciously use various blood products. The management for various blood-related issues is primarily you need to look for optimizing hematopoiesis, iron supplements, nutritional supplementation is the key factor. Also try to minimize the blood loss and bleeding during the intraoperative period. The surgeons use cautery, the position-related things needs to be taken care of, and harness and optimize physiologic tolerance of anemia. And that's why the exercise tolerance, the rehabilitation, where exercise is one of the aspects where you increase the tolerance capacity of the body to tolerate these events, needs also be taken care of rather than just transfusing them with blood products. The next important aspect in these patients are when they are posted for surgical procedure is the cancer pain, and they may be requiring opiates. Now, cancer pain is one of the important issues because the cancer sometimes is little extensive and they will be compressing over the tissues will be expanding. They can compress over various plexus and nerves, and hence these patients will have pain. So these patients may be started on preoperatively morphines, and if you stop them these morphine or any other opiates, stop them immediately before the surgery or don't supplement them, these patients will have a lot of withdrawal syndrome, and hence you should be very cautious in choosing these drugs. They need to be continued intraoperatively, and you should need to provide them additional analgesic agents for managing pain in these patients. Also, these patients do have special concerns in the post-operative period because after extensive surgery, these patients will be in the ICU, and hence they may have unrelieved pain, they have inadequate sedation, they may have inability to communicate, difficult sleeping, hallucination, nightmares. At times there could be physiological dysfunction of various body systems. And hence, they will have more of a post-traumatic stress disorders, and hence we should be very, very cautious in taking care of various aspects in these patients in the post-operative aspect. The management of pain is important because these patients will be on multiple catheters, the suction drains, and so on and so forth. And hence, you should be very, very cautiously providing them a comprehensive assessment of pain and manage them accordingly, because otherwise these patients will have a lot of concerns as a part of post-traumatic stress disorder. Not only this, they will have issues on various body systems. They can have cardiovascular issues, the hypercoagulability, and they can also lead to a pain itself is a reason for cancer recurrence. It can lead to immune suppression, catabolic condition, and hence it itself can lead to cancer recurrence. And hence should be very, very careful when you are managing these patients. So to prevent all those issues which I have just mentioned, it is very, very important that pain assessment and response of therapy should be performed regularly in patients, not only in pre-operative period, but also post-operatively, to provide them good pain relief, and hence to provide various physiological changes or derangements that can happen because of pain. These patients, depending upon the severity of pain, can be given the WHO ladder for these patients and prevent them. Coming to last couple of slides, I was just mentioning intermittently about the cancer recurrence, immunosuppression. These are important aspects. When we say the cancer and immune suppression, this can happen primarily because of cancer itself, but also because of treatment they receive. They will have impact on the various suppressive action on the various immune cellular mechanism of the body, leading to immune suppression. Also, the adrenal suppressions may happen because these patients at times may be on steroids, and that can lead to immune suppression. Hence, because of this immune suppression, we have to be very, very cautious in following all strict aseptic precautions, because that can lead to the chance of infection in these. The cancer recurrence is important. The data is emerging where the cancer recurrence can happen, and opiates, primarily the morphine, has been found to one of the factors that can lead to the cancer recurrence, and hence we should be very, very cautious when we are using the pain management strategy in these patients, because that can lead to itself the cancer recurrence. The pain in critically ill patient is more terrible, and you should be, prevent, as I just mentioned a couple of slides back, you should be able to mention that. The cancer recurrence is primarily the interlinked between the control of anesthesiologists, and various anesthetic techniques impact the cellular immunity and leads to cancer recurrence. And it becomes very, very important for us to follow a technique which is important. For example, say volatile anesthetics may have impact on the immune functions of neutrophils, macrophages, dendrite cells, T lymphocyte cells, and NK cells, and that can lead to cancer recurrence. And hence, though we do not have much robust evidence, but we should be cautious using various agents appropriately to prevent cancer recurrence. The regional anesthesia technique provides good pain relief, and it has been found in a preliminary data that it reduces the incidence of cancer recurrence in certain type of tumors, because it does not lead to immune suppression. And as I mentioned earlier, pain itself can lead to immune suppression in chances of cancer recurrence. And if you're taking care of pain much better with regional anesthesia and analgesia, the chances of the pain management is better. The regional anesthesia in breast cancer benefits beyond pain. Yes, pain is one, but it has many other advantages. So I think I will stop at this point of time, and we'll be taking some specific concerns of specific type of surgical procedures in the next section in the next week. So I think I can take a break at this point of time, and I am open to questions, and certain specific techniques like CRS and HIPEC and various, these are very specific procedures we'll be discussing next time. And next time I'll also be discussing a very important aspect of rehabilitation and ERAS protocol, which is important for the management of cancer patients, improving the outcome of cancer patients. So these are the three sessions I will take in next time. the rehabilitation, the ERAS protocols, and some specialized surgeries which are part of cancer. So thank you so much.
Thank you, sir. Thank you so much for elaborately comprehensively covering very latest emerging field with a lot of patient burden in the recent years. The physiology and other things, and the pharmacology and other therapeutic modules are ever expanding. So this is not going to be the only key to get a best outcome. The anesthesiologists have a comprehensive approach and consider each and every aspect of the patient care, right from the preoperative evaluation to the post-operative well-being of the patient, keeping in mind all the time, whatever we do has got an impact on the patient's outcome. So that's why I request all our participants to come out with their doubts and concerns so that we can ask our professor to clear doubts. Any questions from the audience, please? Sir, can I ask one doubt, sir?
Please, sir. Please, sir. I think one question is there by Purnima about the analgesia, use of PCA pump.
Yes, sir. Yes, sir. In the chat box, there is a question.
So I think
Analgesia and PCA.
Yeah, PCA pump is one of the routinely used procedure for pain management. We usually use multimodal pain management. I think sometimes later we can discuss about the whole strategy of pain management. It is usually multimodal. So we use a combination of drugs like paracetamol, acetaminophen, along with NSAIDs, along with opiates and regional anesthesia. So we use a combination of these drugs to provide them a good pain relief, because though it's not robust evidence, but yes, it is coming up that morphine causes some amount of cancer recurrence. But simultaneously, you should also remember that pain also causes cancer recurrence. So you cannot just avoid not giving them good analgesia. But a combination of regional block with the use of local anesthetic agents, giving them a regional blocks. Now we use central block, epidural, plain blocks, tab block, rectal sheath block, and so many blocks which are coming up now. You can use them. And yes, sometimes if there is some contraindication to use of these regional blocks, we do give them PCA pumps. And even with the catheters, we give them PCEA, patient controlled epidural analgesia or catheter analgesia, which is primarily morphine or fentanyl based. So you can use these techniques, but remember that the pain management in cancer patient is multimodal. So don't depend upon single technique to provide them holistic pain. Use a combination of strategies for managing these patients.
We have one more question, sir.
Diclol and ketol like drugs that it will aggravate the renal failure, sir. And anesthesia, aseptic condition also, regional anesthesia is preferable, like epidural or regional blocks, because
yes,
they are present, and also local infiltration, cancer infiltration risk, it will be there in us. Infiltration of metastasis.
Right. I think all the three questions are very important, so I'll answer one by one. First, you said about the NSAIDs. Yes, I said that's why I say, whenever you manage this patient, you have to individualize. So that's why I'm not giving you one technique for all patients. So those patients who are having, say, any chance of renal compromise, like for example, say HIPEC procedures, we never give them NSAIDs. The renal procedures, nephrectomies, we never give them NSAIDs. So depending upon the surgical procedures, you can choose the technique of various combination of drugs among the multimodal analgesia. So for example, say breast surgeries, giving one shot of NSAIDs will not harm these patients because there is no risk of renal damage. But yes, if you think, you can avoid the agents accordingly. Second, you mentioned about the immunological issues, immune suppression and infection. That can happen, but that's why I mentioned that this may not be the reason not to give them a good analgesia using regional blocks. So please follow all the aseptic techniques, and which we do follow intraoperatively. Every day we check the catheters, change the dressings in full aseptic conditions whenever you think that it is spoiled up. And you have to take care of all the aseptic precautions during the regional blocks. So immune suppression or the risk of infection is not the reason not to give them a regional block. But yes, you have to follow them diligently so that infections does not happen. The local infiltration, I think this is not a good technique nowadays. For last couple of years, especially with the emergence of various facial plane blocks and the nerve blocks, ultrasound guided plane blocks, the infiltration of the surgical site is not done. And you rightly mentioned, we should be cautious that we are not impinging on the surgical plane to prevent any surgical implantation of the tumor cells. And you should be very, very cautious. For example, in neck surgeries, we do not give them, in neck surgeries, we do not give a blind cervical plexus block, because we may puncture a lymph node and we can cause a metastasis, needle metastasis or seedling of the tumor into distal cells, which will lead to metastasis. So yes, that's the more challenging, and hence the cancer patients are different from other type of surgical procedures, because you have to think of these things. And that's why I was talking about in cancer patients that you have to think which is best for the patient. They need to have an individualized approach for patient management with regards to anesthesia and analgesia both.
There's one more question in the chat box, sir. Professor Nagasamy has asked the role of preoperative radiation for oral cancer options for airway management.
Right. So whenever these patients receive radiation therapy or chemotherapy for head and neck cancers, they will have a lot of issues. They will have a lot of mucositis, which will subsequently lead to fibrosis, and there will be reduced mouth opening. There will be the neck will be almost fixed. There could be neck skin changes, which will subsequently heal up with a lot of scarring, and hence the neck mobility will also be affected. They can have trismus, the tongue mobility, the pharyngeal structures mobility, they are all hampered. Now, I think sometime I can request sir if we can take a session on airway management in head and neck cancer patients. But these patients, you have to take a decision between two aspects. One, whether we need to go for awake airway management in these patients vis-a-vis airway management under anesthesia. So in case of any issues, specifically head and neck surgeries, we usually follow awake airway management in these procedures, because this is very tricky. And once you induce anesthesia, and if there is airway difficulty, even the surgical airway is difficult because of a lot of fibrosis and all those issues. And hence awake intubation is preferred in case if you think that the airway is hampered. Simultaneously, whenever you are managing these patients, you should be cautious that a difficult airway cart along with various equipments and expertise must be available when you are managing airway for these patients. At times we use video laryngoscope, at times we use second generation supraglottic devices and manage the patient or intubate through it, or most of the time we are going for awake fiber optic guided tracheal intubation in these patients. You should always be ready with surgical airway in these patients, because at times you can stuck up and there could be issues. And hence you should be very, very cautious in those patients who have received radiation therapy, or I will even add chemotherapy for head and neck cancers for airway management. I think next question is post-chemotherapy lung involvement, how to optimize before surgery. I think I will take this question next time when I will be talking about the preoperative prehabilitation in these patients. I will be taking you through that, which are the prehabilitative measures that should be followed in these patients to improve the functional capacity. So can I go on to ask more questions, sir? There is
yes, please, sir. There's one more question.
So this is from
Dr. Pratik Shukla.
Yeah. So
anesthetic drug dose. Is there any modification or normal dose which we use regularly? Any drug interaction which are to be kept in mind in patients are undergoing concurrent chemotherapy?
Right. So this is again a very, very important question. We need to understand, we need to individually assess a patient. For example, a patient who has received chemotherapy and have some liver dysfunction or have some renal dysfunction, obviously we have to alter the dose of the drugs accordingly, because these patients, if they have some renal dysfunction or liver dysfunction, if a drug is being metabolized from the liver, for example, say morphine, we have to come down with the dosages. If something is being excreted from the kidneys, we should be cautious. The duration, for example, in neuromuscular blocking drugs, the dose needs to be decreased, the duration needs to be increased. At times, if there is some renal or liver dysfunction, we'll try to avoid the drugs like vecuronium. We'll try to use drugs like cisatracurium, which will be independently metabolized by Hoffman degradation. So this means the use of or change of a particular drug would depend upon the individual assessment. Similarly, sometimes these patients will have residual effect on the heart function. They may have residual cardiomyopathy. So maybe rather than using the thiopentone, you may have to use etomidate in these patients. So this means that the impact of the radiation therapy or the chemotherapy on the organ systems needs to be looked for, and accordingly you need to choose the drug. Sometimes you need to change a drug, for example, from thiopentone to etomidate, or from vecuronium to cisatracurium, and even sometimes you have to decrease the dose. So sometimes you need to require the use of additional monitoring tools. For example, if somebody has liver or renal dysfunction, we use the neuromuscular monitors for these patients so that we can give the drugs accordingly. And even extubation, once the recovery of the neuromuscular blocking effect, we can give them antagonize the residual effect so that these patients are extubated safely.
Thank you, sir. And I would like to add one more thing to this. The patients, even though they are young and they don't have pre-existing cardiovascular disease, all cancer patients receiving potentially cardiotoxic drugs should be evaluated according to ACC/AHA guidelines. And accordingly, the anesthesia monitoring and management should be planned.
Absolutely, sir. Absolutely. I mean, it has to be an individualized approach. So based on your clinical examination, you should go ahead and do the required further investigation. But to add on, there's nothing called a routine set of investigation that needs to be done for all patients. So please don't write starting from a chest X-ray, hemoglobin, CBC, echocardiography, PFT, VQ scan for all patients. Because depending upon the individual disease, sign and symptomatology, the drugs a patient has received earlier, you can think of the additional investigation modality that probably would change your management plan. And accordingly, you need to choose the monitoring tools intraoperatively and postoperatively also.
Yes, sir. Thank you, sir. And next question is, your suggestions for management of patients who are taking native therapies and alternative and complementary oncotherapies and their impact on our anesthesia management plans.
I think this is a very important question, and this is quite common in India also. And we don't have much evidence on various complementary therapies that are being given, because there are a lot of homemade therapies from Ayurvedas, from Unani, from homeopathic. And in addition to it, there is very other homemade therapies also using some jadi booties and plants and herbs. So these all complementary therapies do have an impact on the management of patients. But the other aspect is we are not very sure, because majority of time patient even does not know that. He will just say that he is receiving complementary therapy. We do not know what is the nature of the therapy. For example, certain drugs will have impact on the coagulation system. So we do not know whether they are have some impact on the coagulation system. So they can have increased bleeding. And we have seen patients who have increased bleeding intraoperatively. We do not know exactly what the reason is. And these drugs are usually do not have the prescription with the ingredients into it. So they will just get from packets and all those products. So sometimes these becomes an issue. So always try to assess these patients, what type of therapies are they taken care of. But on the other hand, certain native therapies and complementary therapies, including good things, for example, say like yoga, exercise. So these are good for us. So when we talk about the prehabilitation, if somebody is taking, we try to encourage them. If they say that we are doing specific some yoga therapies or pranayams for treating a particular type of cancer, we always encourage them, because we know that yoga therapy or physical exercise therapies are not going to harm or have any adverse effect. They will have all the beneficial effect. So try to identify what type of therapies they know. If you think that therapy is not interfering, like for example, physical therapy, yoga therapy, encourage them to continue. But if you think they are taking certain drugs, try to get the prescription of drugs and try to identify what components they have. and try to manage your perioperative care accordingly, because some of them will have, some of the drugs even in the ordered therapies have steroids. So that's why if you know that these contain steroids, then we have to supplement them with additional steroids in the perioperative period. Otherwise, they will have a lot of hemodynamic fluctuations. And if we don't know what actually is taking it, then yes, we have to follow all precautions. Maybe if you want to just add on the side of adverse events, do monitor them nicely, be cautious. If during IV cannulation you feel that patient is having little more bleeding, try to avoid the central urexal blockade. That is what we do sometimes when we do not know what actually is causing coagulation. LFT is okay, everything is fine. We try to avoid them central urexal block. We give them peripheral ultrasound guided facial pain blocks or keep them on PCS. So this is how we have to look for, and I fully agree this is a little challenging at times, because we do not know exactly what's the nature of these drugs. If we know, we can always find out that what physiological changes they bring about.
Thank you, sir. And one more question is, role of onco-anesthesiologist as a perioperative palliative care physician.
I think this is a good question, because we are running our not only DM Onco-Anesthesia courses, we do have MD palliative medicine course also, which is a 3-year degree course after MBBS, and almost is running from 2016, almost 5 to 6 years now. And it is a separate course. But as a part of DM Onco-Anesthesia, it is a part of their training to understand palliative management also, because anesthesiologists are good in regional blocks. They understand the opiates much better. They are also good at taking care of the respiratory physiology, pleural effusion, ascites stepping, putting up central blocks. So I think the role of, I'll just not say onco-anesthesiologist, the role of anesthesiologist is very good for taking this specialty of palliative care also. So anybody who wants to see how we are working, so that you are most welcome to come to us, see for a couple of days and see what we all are doing for palliative care part also, because especially those who are working in cancer centers, palliative care is emerging. And not only cancer centers, we have emerged ourselves outside the cancer center. So we have recently started providing palliative care to non-oncology setting. Like for example, say we have just started, it will take some time to settle down the palliative care for advanced heart failure patients, advanced renal failure patients, advanced neurological diseases. We are looking those patients also as a part of palliative care. So I think those whosoever is interested, they can join some fellowship programs which are being conducted at various places. There is a certificate course in the palliative care that can also be done, which is done twice a year. There are also fellowship programs like in Calicut, which has been done. And if you want to observe, you're most welcome to see and then take a decision. But yes, it becomes our duty whether the patient is operable or not operable. But I think as a humanity, whatever the status of the patient is, anesthesiologists are the best person to provide them comfort care. And that is what we are looking for. And anesthesiologists are one of the best person who are well versed in pain management, and they can provide comfort care to these patients from other symptoms management also.
Thank you very much, sir. Thank you for your kind invitation for all of our students and other faculties to take part in the fellowship and other observations opportunities in your premier institute. So arising out of this suggestion, may I request your kind help to throw some light on how to approach and what are the opportunities available for our students all over Indian Railways and otherwise also, how to approach and how to take part in the academic activities like the one you mentioned just now, sir. Or we can have a separate session on that.
Separate session on what's the academics part?
Yes, sir. How to approach and where to approach and what are the educational opportunities available in the premier institutes like observership or fellowship, and
I think first of all, I must congratulate to your team, sir. You are doing a wonderful job to organize these type of webinars for your students, and I'm sure that they are lucky to get you as and your team as one of the key person to organize so that these people are benefited. And I can say that you should catch your students should catch hold of you to get all the advantages of learning from your vast experience various anesthesia practices. So that is one aspect. But yes, nowadays we have many centers which are working for super specialty like DM or DNB programs. We also have various fellowships across India which are being done by various centers, whether we talk about the pain management, whether we talk about the airway management, whether we talk about the palliative care management, whether we talk about the critical care management. So these are the 4 domains, and there are many centers. For example, say AIMS has DM critical care, AIMS has DM Onco-Anesthesiology, AIMS has observership in palliative medicine. Similarly, like Tata Memorial Hospital, Mumbai, Tata Memorial Hospital, Calcutta, centers at Hyderabad, centers at Chennai, Adyar, Chennai, Ganga Hospital is running the fellowship programs. At Gujarat, we have the difficult airway fellowship program for 3 months. Similarly, there are many centers which are running these type of specialty programs which you can join for the learning purpose. Recently, DNB is also opening up DNB onco-anesthesia programs at many places. So that will be an additional tool those who want to learn it. For as far as AIMS is allowed, AIMS usually allows an observership from 1 day to 6 months for those candidates who are working in government sectors. So AIMS usually does not allow observership for those who are working in private sectors, but those who are working in government sectors, they can come and observe any specialty here for up to 6 months. So they will be getting a certificate. They have to get a certificate from their head of the department and head of the institute that you want to work here. You are fully funded from your institute, because AIMS will not be paying you for observership, but they will not be charging any fees also. So that is usually allowed, and you can come. We usually allow 2 to 3 persons at any point of time in our department. They can observe, they can learn, they can see the things, how the things are going on. Similarly, even other centers like those who are willing for various pain management strategies, BHU is doing one, SGPJ is doing one, Ganga Hospital is doing other, and there are many other centers which are doing pain management strategies. For palliative medicine, there is a fellowship program which is done by Institute of Palliative Medicine from Calicut, which is a 1-year fellowship program. This is in hybrid mode. Nowadays, the classes are online, but physical program has to be attended on-site as Calicut twice a year, and then followed by exam, which is rigorous exam. So that gives a very holistic understanding of the palliative medicine. Also, we have certificate program course in palliative medicine, which is 1.5-day teaching program followed by 10 days of observership in any of the certified palliative care centers, followed by an exam and a case reflection. So that again certifies you for the basic management of palliative care. So these are the various courses and program are being happening, and I think nowadays I could see that many of the good webinars are happening at other places. Even ISA National is conducting the PG programs. Similarly, there are various PG assemblies, and for those students, now many things online, I think it's easier for you to interact, because getting leaves and every time to go outside to attend the PG assemblies may not be feasible for each one of the students. But now many of these programs are happening online. So do attend them. Most of the speakers are really very good. They are of repute all over the India, and they have a good experience. I could many times when I hear them, they are very good from the academic points of view, from their experience point of view. So listening to all those good speakers will further help you, just not to clear your exams, but it will also help you to become a good anesthesiologist.
Thank you, sir. Thank you so much. Dr. Dinesh Kumar Sahu.
Yes.
Yes, sir, please.
I would like to thank Dr. Rakesh Garg on behalf of RISA. I would also like to thank Dr. Professor Nagaswamy sir for joining us and encouraging us. And thanks to RISA President Atul Sharma and all the presidents. Dr. Rakesh Garg has spared his valuable time on this Sunday. I hope all the participants, especially DNB students, must have benefited by this basic information on onco-anesthesia. It was very elaborative and informative. Being in a railway setup, they are usually less exposed to onco-anesthesia. So it was very nice knowledge for them to have, and it was very good. So once again, I would like to thank Rakesh Garg and looking forward for many more such academic activity by Dr. Kamakshi and Dr. Rakesh Garg Liason. Thank you.
So much, sir. Thank you so much for this good initiative. It's a learning experience for me also because such a wonderful, nice questions and remarks. So I also
Yeah.
Dr.
Thank you,
Kamakshi,
sir. Thank you. Sir, Atul sir, please.
few lines from my side. I am overwhelmed today to see you all this Sunday morning. Happy to see so many students.
अतुल सर आवाज कम आ रहा है आपका.
Circumstance that. Okay. I feel proud to be a part of elite organization RISA, where we arrange teaching for DNB students by renowned teachers. Our Vice President Kamakshi Selvam has a vital role in teaching the same. And today's topic was very important. And our guest speaker, Dr. Rakesh Garg, has put all the important points in very concise manner. This outstanding lecture is just a testament to the fact that Dr. Rakesh Garg is one of the best speakers of India. Each and every one of us is grateful for the great effort Dr. Rakesh Garg has put in a great lecture. Hope he will continue his support to us and our students whenever needed. He will give his valuable time to us. Thanks again. Over to Kamakshi Selvam.
Thank you, sir. Thank you so much for our kind words. And I, once again, on behalf of RISA and all our students, I immensely thank our guest speaker, Dr. Professor Rakesh Garg, sir. And we look forward to our enlightening sessions in the future on very, very important and path-breaking subjects of anesthesia, sir. Thank you, sir.
thank you, sir. Thank you so much. Have a
Thank
good
you.
day, sir. Thank you.
Shall we sign off this meeting, sir? Thank you.